Good evening all. Respected Sakeena Madam, Additional DHS and State TB Officer, Office bearers of all member associations, respected sir. On behalf of the Coalition of Professional Medical Associations for TB Elimination Kerala, I warmly welcome all of you to today's webinar. As we know, drug-resistant TB is an area that continues to confuse us clinicians from the diagnosis to the treatment initiation. With the rapidly evolving guidelines, new oral regimes, shorter duration of treatments. So staying updated become very essential for every clinician. So to guide us through these practical and program related aspects of drug resistant TB, today we are privileged to have an expert who is deeply involved in TB training and care, Dr. Shiyas Mohammed, who is the pulmonologist at State TB Training Center. Today he will be dealing approach to drug resistant TB, a paradigm shift. So before beginning, as usual, I invite Sakeena Madam, Additional Director of Health Service, for giving an overview of the program. Over to you, Madam.
Good evening, all. First of all, I thank the coalition team for selecting this topic and giving this opportunity. And first of all, I think this current topic, we have to be very careful and we have to listen the topic very carefully and utilize this opportunity because of the importance of the program. DRTB, which is a severe form of TB caused by bacteria resistant to INH and rifampicin. As we know, the two strongest first-line TB drugs, and hence much it is very difficult to treat than the regular TB. And as all of us know, it is caused by improper or incomplete treatment of standard TB. So the importance of both sides to be addressed seriously with the prompt action from from the healthcare service provider side. So treatment adherence, monitoring, and early detection of adverse reactions by weekly follow-up or at least monthly follow-up is also very important. Understanding the newer regime, newer updates, especially there are so many updates in the program also for the management of TB, along with the integration with the National TB Elimination program will be helpful to tackle the challenges utilizing available platforms. For example, we have so many platforms to discuss difficult to treat cases, and in district level also we can have some committees like if there is any need. For the treatment of MDR TB, it requires a longer or more complex regimen, sometimes 20 plus months, and we have newer oral regimen, which is 6 months B-palm regimen. It is a hope, though it remains a challenging infection with a worse outcome than drug susceptible TB. So we must be vigilant and careful in the patient management to prevent pre-XTR and XTR TB, which all of us know. Pre-XTR is a pre-extensively drug-resistant TB, where resistance is to fluoroquinolones also. And XDR TB, which is actually we are afraid of XDR TB. The most severe form is resistant to INH, rifampicin, fluoroquinolones, and the second-line key drugs like bedaquiline and linezolid. Even though we are discussing about MDR TB, I think each early detection, today we are facing so many challenges in early detection and proper management of drug susceptible TB also. So many patients die within a day or two after the diagnosis or before coming the test results. So we have 20,000 deaths in a year, 20,000 plus deaths in a year, and more than 2,000. Sorry, we have 20,000 cases in a year and more than 2,000 deaths in a year, which is a serious matter as far as a communicable disease in Kerala. So we had to work together and jointly we will be able to eliminate TB. Now we are having so many TB-free panchayats, and I think that is also giving in some kind of misinformation that people think that after having the TB elimination status, there won't be any cases in the panchayat. But these are the TB-free panchayat status is achieved against certain target, like 5 or 6 target, and we have to be very much vigilant to maintain the status. So I think today's session will be a contribution to TB elimination, also MDR TB management in our state. And I request prevention is better than cure. And from the feedback we are getting from many of the clinicians nowadays, our most important challenge is like managing cases treated by most of the youngsters or outside newcomers in the system, because they are using high-end antibiotics for a fever or some kind of small respiratory infection. So that is also one of our major challenge. So AMR, antimicrobial resistance, that program is going on in the state. So we can expect a better outcome in near future, expecting all of your cooperation and support. And I think please we can achieve the goal. And please utilize this platform and have an interactive session and discussion. Thank you.
Thank you, madam. Now we will directly move on to the topic. I invite Dr. Shiyas for the presentation.
Good evening. Without wasting much time, I will directly go on to the topic. Actually, this is a very vast topic and it is impossible to cover comprehensively in a short time frame. So I'll be giving an overview or bird's eye view of the most important points in a patient care perspective. So first of all, I will share the screen. Is my screen visible?
Yes, make it full screen.
It is visible
Now
now?
it's okay.
Okay. So, what are the key areas to be covered today? First and foremost, is TB still relevant in Kerala? Then causes of DRTB, NTP approved diagnostic modalities for TB, TB classification by resistance and treatment options. Do all TB or DRTB cases need to be referred to DTC? Pre-treatment evaluation for DRTB, recent updates in DRTB regimens, then about BPALM regimen with shorter duration of treatment and common areas in the DRTB management. The first answer for the first question: what is the relevance of TB and the status in Kerala presently? This was covered in many of the areas which I am going to cover today are covered in previous sessions also. But for the benefit of the members who have not joined in earlier session, I am repeating that again. So India is the TB capital of the world, everybody knows. But what about Kerala? In last year, around 21,290 cases were reported in Kerala in 2023 and around 20,800 in 2024 and around 19,500 cases in 2025, rough estimate. So 20,000 is a big number. In Kerala, there are only 940 panchayats. So every panchayat has around 22 patients of TB. So that is a very big number. So the numbers and stats will be less just like numbers for everybody. If that doesn't occur in our homes or our neighbors or somebody near and dear to us. So it is a very big number and still it is prevalent in Kerala. The numbers are definitely decreasing compared to 10-year back status, but still it is very much significant. So what about the number of TB deaths in Kerala? That also is around 2,000 deaths occurs in Kerala every year due to TB, which is far more bigger than any other diseases, any other individual diseases, in the infectious diseases. There may be cancers or maybe MI or something like that, maybe more than that. But otherwise, among the infectious disease, TB is the number one killer even now. Then what about the number of drug resistant TB cases? Even the number of drug resistant TB cases are also around 735 cases are reported in the 2024 year. So that are the rough estimates of TB cases. Then about the present status, 2025 number of DRTB patients diagnosed till December 10 is 556. Out of that, 140 cases are MDR TB patients. Then 16 patients out of the 140 MDR TB patients, 16 were initiated on shorter oral MDR TB regimen, 41 were initiated on longer MDR regimen, and 83 patients were initiated on the latest BPAL-M regimen, and H monopoly resistant patients were 416. Then what are the causes of DRTB? So many causes are there. Number one cause is the genetic mutation caused by random chromosomal mutation at predictable frequencies. These occur naturally during the division of the microbes. But whereas all other reasons which is given here are man-made or produced by our programmatic deficiencies or the deficiencies from the patient's part. So number one is maybe I will cover the providers or programmer problems. First is delayed initiation of treatment. Like I said earlier, the random mutations occur during the division of bacteria, and in once in 10 raised 1 in 10 raised to 6 division occur, then there will be a mutation, and this mutation will lead on to uh, drug resistant variant development. So if the number of division is more, then the chances of developing drug resistance will increase. So if we are delaying the treatment, what will happen? The number of bacilli will divide again and again, and then ultimately the number will reach more than the 10 raised to 6, the critical limit of 10 raised to 6, and the patient who was earlier as inbuilt drug sensitive TB will be converted to a drug resistant TB. So that is the importance of the early initiation of treatment. Then other problems are also there: unsupervised treatment, then no monitoring of treatment, and patient may not be uh, having proper compliance with the treatment. He may not be adhering, and they may be taking the reduced 5 tablets instead of 4 tablets instead of 5 tablets, or 3 tablets instead of 4 tablets, or instead of daily regimen he may be taking maybe one three thrice a weekly or something like that. So all these are causes of the drug resistant TB in general. Then about presumptive pulmonary TB, this also everybody knows, but I want to stress on one point. Any abnormality in the chest x-ray has to be considered as a pulmonary TB case till proved otherwise, and they should be investigated, thoroughly investigated, to rule out pulmonary TB. Other points everybody know. And also the high risk population like contacts of definitive pulmonary TB, PLHIV, diabetes, malnourished, on immunosuppressants or steroids has to be regularly screened. What is advisable is 6 monthly or a quarterly symptomatic screening, and at least yearly X-ray screening is the latest recommendation. So why we are doing that? Because many of the patients, TB patients who are microbiologically confirmed, will be asymptomatic. So to pick that, we have to do chest X-ray even if they are asymptomatic for high risk patients. Then the symptoms of extrapulmonary TB, symptoms are related to the organs affected, and constitutional symptoms may or may not be present, like fever, loss of appetite, weight loss, etc. But the important point is absence of constitutional symptom does not rule out TB. So, like in films, everybody will be having a picture of a very lean and like bone-like picture of a TB patient. It may not be like that always, and actually nowadays it is a very rare presentation. When the patient is diagnosed very late, then only patient will be having severe weight loss. So, absence of weight loss or absence of fever or such constitutional symptoms does not rule out TB, especially extrapulmonary TB. Majority of the extrapulmonary TB patients, the weight and such constitutional symptoms won't be there. Okay, then what are the NDEP endorsed investigations for TB? So the specificity of the different investigation modalities in the descending order. That most specific investigations are given above. So Microbiological tests. These are the most specific investigations. So that are CBNAT and TrueNAT. Then LPA. CBNAT and TrueNAT is now the default test for doing for the diagnosis of TB. Why? Because these are the tests which are having the most sensitivity other than the liquid culture and solid culture. But liquid culture and solid culture is available only in very higher referral centers. But CBNAT and TrueNAT is freely available even at the Taluk hospitals nowadays. So CBNAT and TrueNAT is the default choice for the diagnosis of TB nowadays. Even for drug sensitive TB, we are going for CBNAT and TrueNAT. We are offering upfront NAT for every TB, presumptive TB or TB suspects. So another advantage is the high sensitivity or low limit of detection. That CBNAT can detect even around 100 by, even if there are 100 bacilli per ml, CBNAT can detect that. But whereas the conventional incidence staining or fluorescent staining, it needs around 5,000 to 10,000 bacilli to get a positive report. At least a scanty report needs that much bacillary count. So the next options are LPA. Usually LPA is not a preferred initial diagnostic investigation due to very low sensitivity, but it is used for the drug resistant detection of the drug resistance after TB is diagnosed by CBNAT or TrueNAT or by culture. Then liquid culture is a gold standard for the diagnosis of TB, but as I said earlier, it is not available universally, so we are not doing for every patient. But still, if we are in doubt and other investigations are negative, you can always go for this liquid culture. And another problem is it will take time. For a positive report, it will take around 10 days minimum, and medium time period is 21 days for getting a positive report. But for declaring that sample to be negative, it needs minimum 42 days of incubation. So that is another problem with the liquid culture. But the advantage is it is having very high sensitivity and very low limit of detection, that it can, depending on the type of lab, the limit of detection ranges from even 10 bacilli per ml can be detected in certain labs. And routinely it is said that around 50 bacilli per ml is the limit of detection for the liquid culture. So that is the best available test. Then the olden sudden staining and fluorescent staining is now not a recommended initial test due to low sensitivity and low specificity also. Maybe due to some other organisms can also give false positive reports. So not an initial diagnostic investigation nowadays. Then whole genome sequencing and targeted next generation sequencing are the upcoming tests, but now it is usually reserved only for difficult cases or patients who are started on BPAL-M regimen only, as the procedure is not standardized nowadays. Some companies are providing that, but still there are some confusion in the interpretation of the results and all that. So now we are not using on a routine basis. So only for these difficult cases we are using that. Then histopathology is the next best option next to the microbiological test. Histopathology is also like around 90% specificity is there. The chances of getting a wrong diagnosis is low. So biopsy, FNAC, cytology can be tried. Even if histopathology and microbiology is not confirmatory, we can use radiological tests like MRI, CT, PET CT, USG, and chest X-ray for the diagnosis of TB. So if microbiological tests are negative and the patient is having signs and symptoms of TB plus histopathology and radiology is suggestive of TB, then we can diagnose the patient as a clinically diagnosed TB and start the treatment. But one more important point is never do the empirical treatment, like whether start the treatment for 1 week or 2 weeks and see the response, and then if the patient is responding, then continue the treatment. Such empirical treatment is not permitted nowadays, except in very rare situations like specific intestinal TB, when there is a confusion between intestinal TB and Crohn's disease. Then we can start the if we are doing all the investigations, including biopsy. If we are not reaching a proper diagnosis, then we can do the uh, empirical treatment. Otherwise, this empirical treatment for TB is not at all warranted. When you are starting the treatment without the microbiological confirmation, plan to start as a full treatment regimen, not as a partial treatment. So everybody will be wondering the famous tests which are routinely done for TB is not mentioned here. The Mando test, IGRA, CVTB. What is the role of Mando, IGRA, and CVTB? Actually, these are used for the diagnosis of TB infection, not for the TB disease. It cannot distinguish between TB infection and TB disease. It can only tell that there might be a possibility of the patient having TB infection. So it should not be used for treatment purpose. The use is actually for deciding whether the person requires TB preventive therapy or not for the TB disease for the full treatment purpose. Another reason is it cannot reliably rule out TB. Many of the patients who are confirmed TB, microbiologically confirmed TB with symptoms, many of them will be negative for this Mando, IGRA, and CVTB test. So we cannot reliably rule in TB with this test. Also, we cannot rule out also, rule in also. Rule in both rule in and rule out is not possible with this test. So it is not at all recommended. Also, diagnostic tests like serology, IgM, IgG, IgA antibodies against MTB antigens, various in-house or non-validated commercial PCR tests are not recommended as TB diagnostic tools as they are often inaccurate. This is also very important. Many of the hospitals are still doing this PCR test, the non-validated commercial PCR test. Actually, the tests of which we are doing like CBNAT, TrueNAT, and LPA are kind of a PCR test, but they are pre-validated tests, not like the unvalidated simple PCR tests. So don't do that. Actually, these are all not at all these are not at all recommended by WHO or NTP. Then tissue diagnosis must be tried in all cases if technically feasible. That is also very important. Then coming to National Drug Resistant Survey, why we are doing the drug resistant test for all TB patients at the diagnosis itself. Earlier, we used to do the drug resistant testing maybe after the treatment failure, or if a person is getting TB again and again, and the patient is not clinically responding, or when the patient is nearing the death. In such cases, only the drug resistant testing was done. But nowadays, it is said to be done at the diagnosis of the initial diagnosis state itself. Why? Because of the survey which was done in 2014 to 16. In that survey, it was found that around 37% of the previously treated patients and 23% of the newly detected TB cases are resistant to at least one drug. That is a very big proportion, and also, INH resistance was found out to be 25% in previously treated and 11% in new cases. So, after this survey report, we decided to start the drug resistant test for all the patients. So that's why we are following this universal DST protocol now, or upfront NAT. Universal DST means universal means for everybody. So DST is done for all patients at the time of diagnosis. So there are a set of minimum criteria to uh, to be fulfilled to say that DST is universal DST is done. So that minimum criteria is the. Am I audible?
Yes, yes, audible.
Hello, am I audible?
Audible and
Okay.
audible.
Okay, so the minimum, so the minimum test required is CBNAT or TrueNAT usually, and in Kerala we are doing an extra test. That is INH also has to be done in Kerala to declare that UDST is done. INH is done through first line LPA. So if rifampicin or INH is resistant in the CVNAT or TrueNAT or LPA test, then we have to do further testing for fluoroquinolones and second line injectables with second line LPA and culture. So that forms the minimum criteria for the universal DST. Also, we have to do the test within 15 days of diagnosis. If you are doing the test after 1 month or 2 months, then we cannot say that UDST is done. So that is universal DST. Then about the low, very low discordance resolution. So this is also a confusion among the clinicians. Many of the reports comes as MTB detected low, very low, high, medium. What are the meaning of that? Actually, the meaning is that low, very low, medium, high, the word meaning itself says. But when it combines with the rifampicin resistance detected, we have to be careful with the interpretation. So low, very low, any type of report, we should not be doubtful about the TB diagnosis part, but there is a catch in that I will tell later. So TB diagnosis, there is no doubt, but the MDR TB part, there are some doubts. So if a low or very low MTB detected report you have received and rifampicin resistant detected is written in that report, then that may or may not be a drug resistant case. So if that patient is having high clinical probability for developing MDR TB, then that can be considered as a true MDR TB. What are the points for considering as a high clinical probability for DRTB? Point number 1, if the patient is having previous history of anti-tubercular treatment, then he is a high risk patient. So no need to doubt the result. So previous history of ATT, then history of contact with the MDR TB patient. Somebody in the house or in the surroundings is suffering from MDR TB, then also we can straight away start with the MDR TB treatment even with low or very low report. So other chances are like if the report is from a follow-up, like after 1 or 2 months of treatment, the follow-up sample is showing the sputum AFB positive, and then after that, if you are doing the CVNAT or TrueNAT, and if in that very low MTB detected and rifampicin resistant, then also you can consider that as true MDR TB. Okay. Then if the patient is not having any of these high risk features and the report is showing this low or very low and the rifampicin resistance detected, then we have to do a repeat test. That repeat test has to be NAT, CBNAT or TrueNAT, and that can be done from the peripheral lab itself. So then if both reports show as the rifampicin resistance detected, then that is a confirmed MDR TB. But if the repeat test or the first line LPA which was sent to IRL lab show that the second sample shows rifampicin sensitive and the first sample at the periphery showed rifampicin resistant, then there is a discordance. Then a third test has to be done for the redressal of the discordance. That third test has to be compulsorily done at the IRL of the C&DST laboratory, and the third test should be compulsorily a NAT test, not a culture, not a consensus basis of the 3 tests, either 2 NAT and 1 LPA or 3 cases of discordance. I hope everybody is clear about the redressal mechanism, and so DRTB committee should take opinion from the
ഷിയാസ് കുറച്ചൊരു ഓഡിയോ ഇന്ററപ്റ്റഡ് ആണേ, കണക്ടിവിറ്റിയുടെ ഇഷ്യൂ ആണെന്ന് തോന്നുന്നു. എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമെങ്കിൽ ഒന്ന് നോക്ക്.
ഡ്രഗ് റെസിസ്റ്റന്റ് ടിബിയുടെ ടൈപ്സ് ആണ് അറിയേണ്ടത്. അത് റെസിസ്റ്റൻസ് പാറ്റേൺ വെച്ചിട്ടാണ് പറയുന്നത്. ഏറ്റവും സിംപ്ലസ്റ്റ് ആയിട്ടുള്ള ഡ്രഗ് റെസിസ്റ്റന്റ് ടിബി എന്ന് പറഞ്ഞാൽ എച്ച് മോണോ പോളി DRTB ആണ്. അതിനകത്ത് INH will be resistant and are sensitive. Other first line drugs may or may not be resistant. Then MDR-TB, previous definition was both H and R should be resistant, but the present definition is rifampicin resistance detected. Other drugs may or may not be resistant എന്നുള്ളതാണ് latest definition. Then pre-extensively drug resistant TB, MDR-TB definition with additional fluoroquinolone resistance detected. Then XDR-TB or extensively drug resistant TB, that is pre-XDR-TB criteria with resistance to other type A, group A drugs like linezolid or bedaquiline or both linezolid and bedaquiline detected. Next slide. Then the treatment options are for the H monopoly TB, 6 to 9 months treatment of H monopoly DRTB regimen, that is LRZ. HRZD is a typical treatment for the DSTB, but H monopoly TB, INH is not effective, so INH is replaced with levofloxacin. That is LRZD for 6 to 9 months without any IP or CP. Then options treatment for the MDR-TB regimens are 6 to 9 months of BPALM short oral regimen is the latest treatment regime. Then 9 to 11 months of shorter oral MDR-TB regimen is the second option. Final option is a 18 to 20 months longer oral MDR or XDR-TB regimen. Next slide. So how to select which regimen has to be given? That is decided by this chart. This chart seems to be very complicated on first vision, but actually it is very simple if we are doing it on a step-by-step basis. So first, if we are getting all the test results as sensitive, we can simply start DSTB regimen. If we are getting INH resistance in first line LPA report, then we can start H monopoly regimen, that is given in the right hand side. So INH resistance H monopoly regimen has to be started. Then we have to do second line LPA and culture test. If in that any of the drugs show additional, like pyrazinamide may be showing resistance after the culture report, then we have to modify the H monopoly regimen accordingly. Pyrazinamide has to be removed and alternate drugs has to be started. Also, at any stage, if we are getting a rifampicin resistant report in the follow-up period, we can switch the regimen to MDR-TB regimen after the start of the H monopoly regimen. So that is the H monopoly regimen, decision regarding H monopoly regimen. Then if you are getting an R resistance report and you have confirmed if that report is having the high probability of the MDR TB, if that patient is having high probability of the MDR TB regimen, you can consider that patient for starting the MDR TB regimens. So the MDR TB regimens, the default first choice regimen is the latest BPAL M regimen. That is to be given as a default choice for all patients. But there are certain inclusion and exclusion criteria for the BPAL M regimen. First among them is the age criteria. Minimum age for starting BPAL M regimen is 14 years. So if the patient is below 14 years, you cannot start BPAL M regimen. Above 14 years, if other inclusion criteria are met and no exclusion criteria, then you can start BPAL-M regimen. So BPAL-M regimen is the first option. Then if the patient is below 14 years or there is some exclusion criteria for the BPAL-M, you can look whether the shorter 9 to 11 months of shorter oral regimen can be tried for such patients. You have to check the eligibility criteria for that, and if eligible, you can give that. If the patient is not eligible for the shorter oral MDR regimen also, then the longer oral regimen can be started. There is no exclusion criteria for the longer oral MDR TB regimen. Actually, if there are some contraindications or adverse drug reactions against some of the or the resistance against some of the component drugs in the longer regimen, you can replace the drug with the, another drug which is also in the then also the name of the regimen don't change. So that is in a nutshell about the various regimens of the MDR TB regimen. Next slide. So coming to INH monopoly DRTB regimen. INH monopoly that I have earlier said that when the reports show that H resistance is detected on first line LPA, that patient is a candidate for the H monopoly regimen, and such patients we have to the where can we start the regimen? Actually, that is also a very important question. Actually, H monopoly both DSTB and H monopoly DRTB, the treatment can be started in the peripheral hospital itself. No need to refer the patient to DTC or the medical colleges for starting the H monopoly DRTB regimen. Even the peripheral doctor can start the regimen. So, what are the pre-treatment investigations required for the H monopoly DRTB regimen? No additional investigations are required for starting the H monopoly DRTB regimen. The routine investigations which are done for the DSTB is sufficient for the H monopoly DRTB, starting the H monopoly DRTB also, like blood routine, RFT, LFT, HIV, HBS. So no special investigation is required for the H monopoly DRTB, starting the H monopoly DRTB regimen. Next slide. So starting the H monopoly regimen can be done by the peripheral doctor, but like I said, the routine regimen is the LRSD for 6 months or 9 months. So if the patient requires some type of treatment modification, like if the levofloxacin is resistant and levofloxacin has to be replaced with some other drug, or the treatment duration has to be extended from 6 months to 9 months or 12 months or something like that, then that change in treatment duration or the change in treatment has to be done from the district TB center or the DRTB, wherever the DRTB committee is there. Okay, next slide. Oh, so these are the weight bands. This weight band is slightly different from the DSTB weight bands. Then the sequence of the changing of drugs is also given. If levofloxacin or pyrazinamide cannot be given due to ADR or due to resistance, then it can be replaced with linezolid. If linezolid also cannot be given, replace with clofazimine plus cycloserine. If both levofloxacin and pyrazinamide cannot be used, add two drugs among the three: linezolid, clofazimine, and cycloserine in the order of preference based on resistance, tolerability, and availability. If R resistance is detected at any time, the regimen has to be switched to MDR-TB regimen. That is about the H monopoly regimen. The only the initial part you need to know. The replacement part usually will be done at the DTC level or district DRTB committee level. Next slide. So the follow-up monitoring duration, like I said, it is 6 to 9 months. Clinical plus weight follow-up should be done monthly till the end of the treatment. Actually, this is a national guideline. In Kerala, we are doing bi-weekly follow-up. So clinical follow-up is bi-weekly follow-up. Then sphere microscopy must be done monthly from month 3 onwards till the end of the treatment. If it is 6 months, then till 6 months. If it is extended to 9 or 12 months, till the end. Then culture. Culture should be done at multiples of 3, like 3 months, 6 months, and like that. So, if any of the culture or the sphere microscopy comes as positive, then we must be suspecting that the regimen is not effective or the response is very slow, and we have to suspect additional resistance. So, we have to do a repeat DST test if any of the follow-up tests comes as positive. Then next slide. Then other tests like CBC, platelets, TSH, LS, chest X-ray, all and such tests are repeated on the clinical indication basis. No guideline for repeating that periodically, but in Kerala, actually, we are doing that regularly. Okay, next slide. Then about the weight band change, like DSTB, DRTB also, if the patient's weight increases or decreases by 5 kilogram, then we have to change the uh, dosage of the drugs if that weight band is crossed above or below. But for pediatric and the that should be effective after the completion of the drugs which are already provided to the patient, not immediately. But for the pediatric patient, if the weight crosses the limit, then you have to change the dose immediately. You should not wait for the next box of medicine. Next slide. Then extension criteria. Usual their duration is 6 months, but it can be extended directly to 9 months in certain conditions in patients with extensive disease or uncontrolled comorbidity, extrapulmonary TB, or modified uh, regimen. Also, if the smear is positive at the end of month 4 is found positive, there should be no monthly extensions. It should be in the multiples of 3, like 6, 9, 12, like that. Also, if the patient sputum smear or culture is positive after the fifth month, then that patient should be declared as treatment failed and the patient should be reevaluated as per the diagnostic algorithm for non-responder. Also, if the patient is not responding clinically, radiologically, even without additional resistance to R, he or she may be considered as a probable MDR TB, and MDR TB regimen can be started. But that power comes only with difficult to treat TB clinic at the state level or national level. An individual doctor cannot decide on the clinical MDR TB. Earlier, MDR was considered as purely a microbiological or lab diagnosis, but now there are provisions for diagnosing this clinical MDR TB, but that should be done by the difficult to treat TB clinic at the state level or national level only. That should not be done at the district level or by the individual doctor. Next slide. So to summarize H. monopoly resistance, when there is proven rifampicin resistance not detected and H resistance detected, that is H. monopoly, then the treatment can be started at the peripheral health facility level itself after pre-treatment evaluation. Then regime is 6 months of LR-RISD replacement as per the replacement sequence when there is additional resistance detected or adverse effects, non-availability of the drug. Then in such cases, the treatment has to be modified. Okay, there is no separate regimen for children, HIV, pregnant women. Also, okay, next slide. Then a few words about the difficult to treat TB clinic. Difficult to treat TB clinic is an initiative to support the care of the DRTB cases in appropriate patient management. Actually, it was designed for the inclusion of DRTB patients only, but now we are including the difficult to treat DSTB cases also. This is constituted at the state level and national level, and both public and private cases can be discussed in this forum. This will save the doctors will get appropriate decisions from the forum, and that may save the doctor from later medical legal litigations, and also the patient also will be benefit to get the right decisions. Also, there are center of excellences in DRTB care. 5 institutions are declared as center of excellence in October 2002. One is NITRD New Delhi, then RBPMT New Delhi, JJ Hospital Mumbai, then the Tambaram Hospital and Lucknow Hospital are also there. That works as the hub and spoke model. The peripheral hospitals are the spoke. We are the spoke. We are connected to the Tambaram Hospital. Okay, next slide. So the difficult cases in Kerala will be discussed with the Tambaram. Then the MDR TB regimens, the preference of order is like I already said, the first choice is the latest BPALM regimen as it is having the shortest duration. The treatment will be finished within 6 months, just like the conventional DSTB treatment, and in some cases it may be extended to 9 months treatment. So if that is possible, we will be giving BPALM regimen. If BPALM regimen is not possible due to some reason, then the 9 months shorter oral regimen can be tried. If that also is not possible, then the patient should be receiving the longer oral regimen. Next slide. Then about the BPALM regimen. BPALM regimen is of the shortest duration presently. Why? There are two reasons for that. Due to the inclusion of the newer drugs bedaquiline and pretomanid in the regimen. The unique property of the pretomanid is that it is having dual action. It will inhibit mycolic acid biosynthesis and blocks the mycobacterial cell wall production. Also act as a respiratory poison against non-replicating bacteria. So it can act against both replicating and non-replicating bacteria. This is a unique characteristic of this pretomanid. All other conventional TB drugs will be having the bactericidal action only at the against the dividing bacteria, but the pretomanid is having the bactericidal action against both the dividing and non-dividing bacteria. So the TB regimens are given for the longer duration due to the non-action of the TB drugs against the non-replicating bacteria. So some bacteria will be dividing very rarely. So to cover the non-dividing bacteria, we are giving for the extra duration. But if we are adding the pretomanid to the regimens, we can shorten the duration. So that is the rationale of the short duration of treatment by using pretomanid. Then linezolid and moxifloxacin, of course, is there, older drugs. Next slide. Then what are the inclusion and exclusion criteria for the BPALM regimen? The inclusion criteria is the age should be more than 14 years and there should be a report of the rifampicin resistance. Then history of exposure to the constituent drugs should be less than 1 month. If the previous history of exposure to the constituent drugs are there, then there should be a proven record that the drugs are not resistant. Then the exclusion criteria or contraindication should not be there. The usually said contraindications are the QT prolongation. Corrected QT interval should be less than 450. If it is more than 500, that is like contraindication. Then also the severe forms of extrapulmonary TB is also like an exclusion criteria. Simple isolated lymphadenopathy can be considered for BPALM regimen, but other forms of extrapulmonary TB like bone TB, CNS TB should not be given the BPALM regimen. Okay, next slide. Also, pregnant women, lactating women, etc. also cannot be given the BPALM regimen. If they are willing for abortion and after abortion they can be given, or if they are willing for the formula feeds, then that they can also be considered. What are the relative contraindications? Relative contraindications are mainly due to the drug interactions with the bedaquiline and the linezolid. So most of the strong enzyme inhibitors are having relative contraindication with this regimen. But the clinician can decide after taking the pros and cons whether to start the regimen after forceful discussion. Then other lab investigations like low hemoglobin level, low platelet count, low absolute neutrophil count, and higher serum creatinine are also relative contraindication. The doctor can decide. whether to give or not in such cases. Next slide. So, important point is extensive pulmonary TB is not a contraindication for BPAL-M regimen, whereas it was a contraindication in case of shorter oral MDR TB regimen. That is the main advantage of the BPAL-M regimen. So, next slide. Pre-treatment evaluation. Pre-treatment evaluation, the main difference is apart from routine investigations, TSH was a must-do investigation in case of the traditional shorter MDR regimen and longer MDR regimen, whereas the TSH is not a must-do investigation in case of the BPAL-M regimen. Still, we are doing TSH investigation for all patients because after the investigation, some of the patients may not be eligible for BPAL-M. So to save time, we will be doing TSH investigation also. So RBS, HIV, blood count, LFT, RFT, serum electrolytes, UPT, chest X-ray, and ECG are the routine pre-treatment evaluations, along with the necessary consultation like medicine consultation, opthal consultation, then gynec, and relevant cardio, etc. Okay, next slide. So the pre-treatment counseling. So pre-treatment counseling should be given for both the patient and also the treatment supporter. Also, we have to take the history of the other concomitant drug intake. Sometimes a patient may be taking Ayurvedic or Unani drugs also. That also can produce the drug interaction. So that is also very important. Also, avoid magnesium supplements or magnesium containing antacids for 2 hours before and after the drug intake, as it can decrease the absorption of the fluoroquinolones. So next slide. Also, another important point is bedaquiline is having a longer half-life. Calculated half-life is 24 to 30 hours in the blood, and terminal half-life in the tissue is about 5.5 months. So that means that even if bedaquiline is stopped today, then the patient will be having bedaquiline in his tissue for the next 5 to 6 months. So if the patient is interrupting treatment, that will result in bedaquiline monotherapy because the other drugs will be washed out, but the bedaquiline will be still in the tissues, and that results in bedaquiline monotherapy, and that may lead on to the development of the bedaquiline resistance and its amplification. So it is strongly recommended that all treatment regimens, including BPAL-M, are to be administered under direct observation. That means dose should be followed minimum 6 days a week. That is 85% of the doses should be under direct supervision. Actually, this is the most important point of this presentation. The actual effectiveness of the TB regimens depends on the adherence of the patient. Many of the trials are showing around 80-90% result for these newer regimes, but when we are implementing in the field, we are getting lesser, like 70%, 75% reports in many of the states. Kerala, it is around 80%. Next slide. So the doses of the drugs in BPAL-M regimen. Bedaquiline is given in two type of doses. Bedaquiline for the first 2 weeks. Bedaquiline comes as 100 milligram tablets. For the first 2 weeks, it is given as 400 milligram tablets daily. Then from the third week onwards to the 26th week or 39 weeks if extended, that has to be given 2 tablets 3 times a week. Then protamanic comes as 200 milligram tablet, and that is given as 200 milligram daily. Then linezolid as 600 milligram daily. Then moxifloxacin also 400 milligram once daily. Then in some patients, the treatment will be extended to 39 weeks. That I will tell later. Then the follow-up schedule. Clinical review should be done bi-weekly in Kerala. Then CBC, platelet, and ECG should be repeated at day 15 and day 30. Then monthly till month 6 and more frequently if clinically indicated. Why we are giving special importance to the CBC and ECG is related to the ADR. Bone marrow suppression is one of the commonest and significant ADR of the linezolid. So it is pretty common. So we are doing routine uh, monitoring for that. And ECG, QT prolongation, like I said earlier, corrected QT interval may be increased in many of the patients and can result in torsade pointers. So that should be routinely monitored. Then visual acuity and color vision test, the one which written in the slide is actually wrong. That is in national context. In Kerala context, actually we are doing the visual acuity testing in every visit. That means 2 weeks, every 2 weeks. Then smear microscopy usually not warranted in the BPALM regimen, but it may be done with along with culture. Then culture should be done monthly from month 2 onwards, that is at 9, 13, 18, 22 and 26. Then DST will be done whenever the culture is, any follow-up culture is positive. Then chest X-ray and LFT at the end of month 3, then other investigation. Anyway, I will skip this next slide. We are running out of time. Then another important point is long-term follow-up should be done for all TB patients, whether they are DSTB, DRTB, or even if they are on TPT also. The 2-year follow-up is a must. Like 6 months, 12 months, 18 months, and 24 months, they should be followed. Then some of the commonly reported ADR of the second-line drugs. Nausea and vomiting is usually what we say in pharmac test, it will be there for all drugs. Ethionamide, PAS, and pyrazinamide and bedaquiline is a usual culprit, 7 the second line drugs, so, although other drugs can also produce that. Then last, rash and allergic reaction can also be there, can be produced by any drug. Then QTC prolongation, usually bedaquiline, fluoroquinolone, cofazamine, delaminid, and pretomanid are the causating drugs. That is, actually it can be a very life-threatening disease, so we should be regularly monitoring the QTC prolongation and also monitor other drugs taken by the patient. Patient may be taking other drugs without telling us. So we should inquire specifically about other drugs, which even PPIs can cause drug interaction with the these drugs and produce a QTC prolongation. Then peripheral neuropathy. Peripheral neuropathy is the most common adverse drug reaction among the BPALM and linezolid containing regimens. Around 60 to 70% of the patients will be having some degree of peripheral neuropathy in linezolid containing regimens. Also, optic neuritis for ethionamide linezolid. So vision also should be regularly checked. Then myelosuppression for linezolid. So we should be looking for anemia or pancytopenia for all the patients receiving the linezolid. Then hepatitis can also be produced by multiple drugs. Another important ADR is the occurrence of the psychiatric disorders. It can range from the frank psychosis to depression, suicidal ideas, anything can be possible. We have to suspect that in right time and refer the patient to a psychiatrist to rule out the psychiatric disorders that can be easily missed. Then hypothyroidism can be produced by ethionamide and PAS. Then seizure disorder. So then linezolid and bedaquiline are the most common drugs producing significant ADRs requiring regimen modification. Next. So linezolid toxicity, like I said, it is very common. Around 70% will be having some type of peripheral neuropathy. So we are having predictors of the occurrence of this ADR. Usually they will be having diabetes, PLHAV, hypothyroidism, substance abuse, low BMI, abnormal electrolyte levels. Such things may be there, which can be predictor of the development of the linezolid toxicity. Next slide. Then these are the grading of the linezolid toxicity. Focus on the grade 3. So grade 3 means peripheral neuropathy. Usually there may be inability to distinguish hot or cold water, worsening of symptoms at night or increasing leg pain while walking, slipping of footwear without knowledge, inability to place his soles on the ground, frequent sore or ulcers on the feet, diminution of vision. Diminution of vision means minimum grade 4 ADR. So the importance of this grade 3 and grade 4 is usually such areas need stoppage of the, at least temporary stoppage of the uh, drug. And if even after stopping the drugs and we are giving a drug holiday, uh, then we may be able to restart the treatment. But if it is going back to grade 3 and grade 4 again after restarting, then we may have to permanently decrease the dosage. Sometimes even after permanently decreasing the dosage from 600 to 300, patient may be still having this ADR. In such cases, we have to stop the linezolid. And if we are stopping the linezolid, we cannot continue the regimen. Okay, next. So myelosuppression usually it will be a very reversible side effect. So usually we can manage that with blood transfusion or maybe lowering the dose. Usually will subdue the reaction, and usually patient will be okay after that. So that usually won't be a problem. Optic neuritis, you should stop the treatment then and there itself. Okay, next. So the peripheral neuropathy management, it is slightly different when it occurs before 9 weeks and after 9 weeks. Before 9 weeks, if the peripheral neuropathy occurs and you cannot, then you cannot adjust the dose, decrease the dosage. You should be giving full dosage. If we are not able to give full dosage of 600 milligram, then you have to stop the BPALM regimen and start an alternative longer regimen or shorter regimen. But if it occurs after 9 weeks, then the patient may be tried for a lower dosage of linezolid of 300 milligram. And if he is tolerating 300 milligram, then the patient can be uh, given the treatment BPALM regimen for 39 weeks. Next slide. 39 weeks. So this is a indication, one of the indications for the extension of treatment from 26 weeks to 39 weeks. So if ADR occurs against linezolid or moxifloxacin, then the treatment can be extended to 39 weeks. Next. So QT interval prolongation. I showed everybody knows what is QT interval, but the important point is the usual ECG machines available in our hospitals are produced by BPL. The BPL machines will be showing the corrected QT. QT will be same in all type of machines, but the corrected QT is an important measurement. This corrected QT which is shown in our machines are usually prepared by the Besset's formula. But what we require in the treatment in the QTC for prolongation is Frederick's formula. This Frederick's formula should be calculated with an app. Like so many apps are available like corrected QT. In that, give the formula name as Frederick's formula. If you are using the Besset's formula, then we may be getting a wrong value, and mostly next slide. Mostly the value which are given by the BPL machines or the Besset's formula is usually a higher value when compared to the Frederick's value, Frederick's equation. So patient may be unnecessarily stopped on the a very effective BPALM regimen due to this wrong calculation. So always use the the QT interval can be directly taken from the BPL or whatever machine is available at our hospital, but the corrected QT interval calculation should be from the proper apps and giving the formula as the Besset's formula. Next slide. Usually the Besset's will be giving a higher values compared to the Frederick's criteria. That is the chart is showing that. Next slide. Regimen extension. what are the criteria? Like I said earlier, if the linezolid dosage is reduced to 300 from 600 after 9 weeks of treatment, then the patient needs to get additional 13 weeks of treatment with the reduced dose, like 26 to 39 weeks. Then also, if there is some severe ADR to moxifloxacin and we have to stop the moxifloxacin, then also the regimen has to be continued as BPAL, not BPAL-M, for 39 weeks. These are the only indications for extension of the treatment. There is no extension for the follow-up positive or additional resistance. Next slide. And interruption management. This is also very important. I am not going to the finer details of the interruption management, but just 2 points. Interruption is taken very seriously in case of BPAL-M regimen. If the patient consecutively interrupt the treatment at least one of the drugs for more than 2 weeks, then patient will be declared as lost to follow-up and we cannot start continue the treatment. Also, if the patient is not taking the treatment properly and in intermittent defaulting is there, and if the cumulative disruption is more than 1 month, then also the patient should be declared as lost to follow-up, and we cannot continue the treatment in such cases. So that should be taken very seriously. So if such thing happens, then we have to reevaluate the patient at the nodal DRTB center or the district DRTB center, and the patient will be started on an all oral longer regimen usually. Next slide. So the management of patients found to be ineligible for the BPAL regimen. This I already told. If the patient is not eligible for BPAL-M regimen, then he will be considered for the shorter oral MDR regime. We check the inclusion and exclusion criteria, and if he is eligible for the shorter oral regimen, he will be started on that. If he is not eligible for shorter oral MDR regimen, then he will be given the longer oral MDR regimen, of which there is no exclusion criteria. Okay, next slide. Then shorter oral MDR regimen, the constituent drugs are given. Two type of regimen are there. Earlier regimen was containing the ethionamide with other drugs. Now we removed the ethionamide as a default choice and we are giving linezolid containing regimen as a default choice. But the linezolid is given for only 2 months and other drugs are given as 4 to 6 months and follow up then 5 months CP. So IP will be IP will be of 4 to 6 months and CP of fixed 5 months. But two different regimens are there. Okay, that much is enough. Next slide. So eligibility criteria of shorter oral MDR TB regimen. It is actually similar to the BPAL-M eligibility criteria, except that the shorter oral MDR TB regimen cannot be given for extensive pulmonary TB disease. Otherwise, all the criteria are almost similar. Also, the shorter MDR regimen can be given for less than 14-year age. So these are essentially the differences. Next slide. So recent changes, as ethionamide has been replaced by linezolid in the regimen, then 9 to 11 months shorter MDR regimen can be given even for pregnant women. Ethionamide is considered as teratogenic when given before the 30th week of pregnancy. So earlier, pregnant women were not given the shorter MDR regime if their pregnancy is less than 30 weeks and they are not willing for MTP. But now, even pregnant women can be given the benefit of the shorter regime due to the availability of the linezolid containing regimen. Also, there was another criteria. Earlier, shorter oral regimen containing ethionamide cannot be given in case of both INHA and CATG mutation was present. But now there is no such as ethionamide is not given. Only linezolid is there, so we can give the shorter regimen even for such patients with both type of mutations. Next slide. So these are the dosages for the shorter oral MDR regimen. Next slide. So how to extend the treatment? Extension of the treatment is done based on the culture done at the fourth month or later after that. Later, if any of the culture which is done at fourth month or fifth month is positive, then we have to extend the treatment by 1 month, one month duration, and the extension should be done maximum to 8 months. If the uh, reports came as positive even after 8 months, then the patient should be declared as failure and should be switched over to an alternate longer MDR regimen. Okay, next slide. Okay, next slide. Next slide. Longer MDR TB regimen. Eligibility criteria, there is no proper eligibility criteria. All patients are eligible for the longer MDR TB regimen. Only thing is that the typical drugs which are given is bedaquiline for 6 months, then levofloxacin, linezolid, clofazimine, and cycloserine for 18 to 20 months. That is a typical composition of the longer oral MDR TB regimen. If one of the drugs is resistant, then that will be replaced with another drug from the replacement group. So the regimen name won't change, but the drugs will change. Okay, that's all. Also, bedaquiline is usually given for 6 months, but it can be given for longer duration in some patients in which a proper regimen cannot be formed with other available drugs due to resistance or adverse drug reactions. In such cases, bedaquiline can be given for the full duration of the treatment. Next slide. These are the dosages of the longer MDR TB regimen. Next slide. Okay, this also was discussed earlier. Next slide. So actually, it was a very long session with frequent internet interruptions. So I am not sure how many of you must have understood the topic properly. So sorry for that. Any doubts?
ഇടയ്ക്ക് ടെക്നിക്കൽ ഗ്ലിച്ചസ് ഒക്കെ ഉണ്ടായിരുന്നെങ്കിലും വളരെ വിശദമായിട്ട് ഡോക്ടർ ഷിയാസ് എല്ലാം എക്സ്പ്ലെയിൻ ചെയ്തു. എന്തെങ്കിലും ക്വറീസ് ഉണ്ടെങ്കിൽ അൺമ്യൂട്ട് ചെയ്തിട്ട് ചോദിക്കാം.
Slides can be shared or if anybody requires.
ഓക്കെ.
So if no doubts, then one or two points as take home message. First one is always try for a tissue diagnosis if technically possible. So technical tissue diagnosis is very important. Then Next thing is don't rely on the Mando test or IGRA or CYTB for the diagnosis of TB, except in very rare situation. One of the indication is the ophthalmic TB, the uveitis or the skin TB, tuberculosis verrucous cutis. In that cases, the uh, bacteriological positivity won't be there, and even the histopathology also won't be showing the typical type of gliomas in such cases. In such cases, where the etiology is usually due to hypersensitivity reaction against the tubercular proteins, then the IGRA or the CYTB positivity can be used as a marker for the TB disease. Only in that two conditions. Otherwise, never use that test for the active TB diagnosis. Also, TB treatment, DSTB treatment can be started from the peripheral hospital itself. No need to refer all TB patients to TB center for starting ATT. If at all some complication is there like LFT derangement, RFT derangement or some other problem, then you can refer. Otherwise, don't refer routine TB patients to the DTC. Also, H monopoly drug resistant TB cases also treatment can be started from the peripheral hospital.
Any other queries? Definitely, the slides will be shared as well as the video after editing will be shared. From 9:40, I think if there are no further queries, I can wind up the session. I personally thank Dr. Shiyas and Team STDC, Arshad sir, as well as State TB Officer Sakeena Madam for arranging this session, as well as the other members from other associations. I am stopping the session. Thank you. Thank you all. Good night.
Nice.